So this I think has been a really informative discussion. But before we end, I'd like to get your final thoughts. So maybe 30 seconds, a minute, and we'll start with Dr. Ganjoo.
Oh, so just to recap, multidisciplinary discussion of patients with sarcoma is very important. As John mentioned, so many different variety of sarcomas. They're all treated differently. Sarcomas are 1% of all cancers. It's impossible for the community physicians or physicians who are not specialized in sarcoma to know exactly how to treat these patients. So sending patients to a tertiary care center is extremely important. Pathology review is important. Getting the input from the surgeons, the chemotherapy physicians, and the radiation physicians is extremely essential for the patient's treatment to go well and for patients to have a good chance. Yeah. And it's always important that first chance is always important.
I agree, and that's the perfect segment into concluding in sarcoma. And Dr. Trent?
Yeah, I'd just like to reiterate the multidisciplinary component, and really the foundation of everything that we do is based on pathology. Whenever possible, a sarcoma specimen should be reviewed by a sarcoma pathologist. We know that 15 to 20% of the time the diagnosis is changed when reviewed by a sarcoma specialist. So that's really the foundation that all of our therapies are built on. And we have so many new exciting therapies like pazopanib, like olaratumab, like eribulin, trabectedin. These are new, and many of them are histology specific. They benefit specific histologies. So we have to work closely with our pathologists, and we have to use their expertise so that we can leverage all of these exciting new therapies for our patients and look forward to potentially some exciting combinations in the future.
Yep, I agree. Dr. Villalobos?
So, again, these are rare cancers. And so because they're so rare and so heterogeneous, we don't have the data like we do in breast cancer, right? So that's why it's so important that there's a lot of nuance involved with how we treat these patients, right? Guidelines can be very effective, but they're not that effective in sarcoma because of the lack of data, frankly. And so that's why it's so important to have colleagues that have experience in these things and to lean on us to try and come up with good plans. And so, again, a lot of new drugs. It's a fascinating field to be in because of the fact that these have very, very different biologies. Like such a widespread amount of whether they be mutated versus modifications in their genome with copy numbers or in translocation-based tumors, and that's what kind of encompasses them all. So we're making a lot of progress here.
Yeah. And Dr. Riedel, do you want to have the last comment?
Yeah. So what I would say is I think it's an extremely exciting time to be in the field. The treatment for sarcoma is becoming increasingly nuanced. We went 40 years with no FDA approval, and we've had 4 approvals in the last 5 years. So I think it's incredibly exciting, and the idea that there is no effective treatment for sarcoma, or the idea of therapeutic nihilism really needs to sort of go away, because we are clearly making advances for our patients.
Yep, I agree. So thank you so much for this really wonderful discussion. So on behalf of our panel, we'd like to thank you for joining us, and we hope you found the peer exchange discussion to be useful and informative.